Bismillahirrahmanirrahim. Assalamu alaikum. Dear students, the topic that I will be discussing with you today is about urological trauma. And basically, the session has been planned so that when you find a patient in the emergency room when they present and they have bruising over the flank, then what are you supposed to think about it? So I will not go into the details about how a trauma patient has to be dealt with. I'm sure my other colleagues who are talking to you in this trauma course have definitely told you that once you receive a patient in the emergency, then the first and foremost thing that you need to do is assess their airway, breathing, circulation, and then the other things. So this is the cornerstone of trauma management. And in the trauma management, what is important is, and this is not very something which is a very rigorous exercise and which takes a lot of time. You can ask the patient his name, and if the patient is able to narrate his name, that means his orientation is fine, and he's also able to speak. And if he's able to speak, that means that his airway is patent, and he's conscious, and he's responding, and he's not in shock. So once you ask the patient their name, the next thing that you ask is where you think you are. That will tell you about whether the patient has had any head injury, has he lost his memory or something like that. And the next thing, at the same time when you're asking the patient his name, you put your left hand on the radial pulse of the right arm and your right hand on the femoral pulse of the left leg. In this way, you are able to see the nature of the pulse. You are able to see if the patient is in shock. You are able to see if both the pulses are normal or not. And I'm sure it will be talked by my other colleagues that what it means if somebody has an absent femoral pulse, what it means if somebody has an absent radial pulse, and what it means if somebody has an absent carotid pulse. That all transforms into recognizable blood pressure changes. Okay, so now with this brief introduction, and having checked, I will suppose that you have checked the patient for their airway, breathing, and circulation. You have to see if there's any bleeding from any place, obviously. And if that is there, you have to apply pressure over there to stop the bleeding at that time. Now, after all this, the secondary survey, now what you do is you examine, I'll be talking about the flank and the renal trauma, obviously. So once you have done all this, you will focus on the flank. You will ask the patient if he has any problem, if he has any pain in the flank. Is he aware that he was hit in the flank by something? Or you also have to ascertain the nature of the injury. Was it a deceleration injury? A deceleration injury typically means an injury which is suffered by a patient once the vehicle they are moving in stops abruptly because of the collision, and due to inertia, the patient and all the organs inside the patient's body keep on moving due to that inertia, and that actually causes the trauma. Now, if you think about the kidney is an organ which is not attached by any major attachments to the body wall or the muscles or any other place. The main attachment of the kidney is by the renal hilum. The renal hilum obviously contains the renal artery, the renal vein, and the pelvis, the collecting pelvis. Okay, so these are the things which suspend the kidney from the body. Apart from that, there is fat all around the kidney. Now, this fat obviously is then enclosed in a Girota's fascia, which is a tough fibrous tissue, and it contains the fat, the kidney, along with its capsule. Now, this Girota's fascia is very important in renal trauma, and I will just, while I go through with this presentation, you will realize why. And then there are some mild ligamentous attachments of the kidney to the spleen and henceforth. So kidney is not actually tied up to anything. So you can imagine that if the person is traveling in a car and they have a trauma, the car collides with something and the car stops abruptly, then this kidney which was attached by this renal hilum will also be moving like this. And once the body comes to an abrupt stop, what will happen is the hilum being attached to the aorta and the vena cava will be fixed and the kidney will keep on moving. Once the kidney keeps on moving, what happens is the renal vasculature will become stretched. And once it becomes stretched, what will happen is the intima will tear. And once the intima tears, then the next thing that will happen is there will be bleeding and thrombus formation inside the renal artery and the renal vein. This obviously, when the thrombus happens, then what happens is the blood supply to the kidney is cut off. Now, once the blood supply to the kidney is cut off, it has a very short time of survival, that is 30 minutes is warm ischemia time, and it can be extended to 2 hours in cold ischemia time. The cold ischemia time is usually utilized when we are doing transplants and the kidney is harvested from the donor, and we keep it in saline slush to keep the temperature very low, and hence the ischemia time is enhanced to from 30 minutes to 2 hours. So bearing this in mind, if a kidney stops receiving blood, the time it can survive only is 30 minutes. So you can understand how critical this analysis is. So with this background, we come to the lecture, and we will just think about how it happens. The organs commonly involved are the kidneys, ureter, bladder, and urethra. But for the sake of this presentation, I will only be concentrating on the kidneys. Okay. So what kind of injuries can occur in these patients who have trauma? The kind of injuries that can occur are blunt abdominal injury, sharp penetrating injury, and then iatrogenic injuries. Now, how do blunt abdominal injuries take place? Blunt abdominal injuries are all sports injuries, except for the sword fighting and dagger throwing, maybe. But apart from that, football, cricket, rugby, etc., whatever you can name, the trauma that is acquired during a sports activity is usually blunt abdominal injury. All the road traffic accidents, they are also blunt injuries. Sharp injuries would be any stabs. They can also be in sports, or they can be in a fight, or they can be gunshot wounds. And these are typically the sharp penetrating injuries. Then the iatrogenic injuries can be due when injury occurs due to some other, when the surgery is being done for some other reason. And at that time, the injury takes place. Typical example for this would be when the spleen is being operated, when the stomach is being operated, when the gut is being operated. So inadvertent injury to kidney can take place. It's not very common, but it can take place. Now, as you know, the kidney is a retroperitoneal organ, which is, I've just explained to you, it is cushioned by the perinephric fat and enclosed in a Girota's fascia. And this is along T10 and L4 vertebra. The ribs interiorly cover the 10th, 11th, and 12th rib, typically cover the interior surface. And the kidneys receive a lot of blood, that is 1.2 liters of blood per minute. So you can understand if somebody has a circulating blood volume of 5 liters and 1.2 liters of blood is circulating every minute, then it will take only 5 minutes for all the blood to go through the kidney. And if a kidney is bleeding profusely, then that is as quick as the patient can lose the blood and go into shock. So blunt trauma is about 80 to 90% of the cases. This can be by rapid deceleration or direct blow. And it has to be suspected in patients who have had trauma to the back, flank, lower thorax, or upper abdomen. All patients who complain of flank pain or who have been diagnosed on a primary survey in chest X-ray to have low rib fractures, in these patients you have to suspect renal injury. All patients who have ecchymosis over the flank or hematuria. And sudden deceleration can also occur when somebody, like a worker or laborer, is on the ladder and he falls down onto the floor. This can also cause sudden deceleration injury, and obviously stretching of the vessels, and obviously the renal injury. You also have to suspect renal injury in patients who come to you with lumbar transverse process fractures. So these are the patients in whom you will suspect that they can be renal injury. What other conditions can lead to this? Pancreatic injuries will also give you flank ecchymosis. They can also give you bruising. Splenic injuries can also. Actually, whatever retroperitoneal structures get injured can give you a bruising over the flank. So because that is the area which is affected. With this pretext, I now come to the grading of the renal injuries. And the grading is very important because based on the grading itself, you have to decide how the patient is going to fare, how the patient is going to be treated, and how you are going to manage this patient. And before I embark upon the staging of the renal tumors, staging of the renal trauma, I would like to clarify that this grading and classification is based on CT scan. So once the patient comes to you and you do a CT scan, which is obviously with contrast, then you see the kidneys and then you classify this according to the grading. Now, the first thing that you need to know is CT scan usually takes about 5 to 10 minutes to do, and further 4 to 5 minutes to arrange the CT scan once the patient is in the emergency. So you have to ascertain that the patient is stable enough to undergo a CT scan. So patients who will be profusely bleeding, patients who will be hemodynamically absolutely unstable, those are probably not candidates for a detailed CT scan evaluation, and I will come to that in this presentation in the following slides. So grade 1, again, I remind you, this is based on CT scan. When you're doing a CT scan, what you see is perfusion of the kidney, and if there is frank bleeding from the kidney, what will happen is that you will see what is called as a CT blush sign. A blush sign is when the contrast reaches the kidney, and from there it is extravasated. Once it is extravasated, then what happens is you can see it as a blush. Okay, it's not that you see the contrast flowing out directly from the kidney, but it is the blush that you see on the CT scan. So in grade 1, there can be contusion. Patient may present with hematuria. All the urological studies otherwise will be normal. And this patient will only have a hematoma. Now remember this patient will only have a hematoma. There will be no capsular breach. This is the capsule, if you can see. This is the Gerota's fascia with the perinephric fat. So hematoma will be enclosed within this capsule, and the cortex will be pushed inside but not breached. Okay, and it will be non-expanding. Now the key features of this grade of renal trauma are that neither the capsule nor the cortex is breached, and there is just hematoma between the two. So this patient is going to be stable if renal trauma is his only problem. He can have an instability due to other problems, but this will not give to instability of the patient. Then coming to grade 2. Now understand in this that in this the renal capsule is also breached, the renal cortex is also breached. In grade 1, what was there? The cortex was not breached, the capsule was not breached, there was just hematoma within it. So grade 2 has a laceration of the cortex, and there is rupture of the capsule, but the Gerota is intact. Okay. Now the difference as we proceed will be in the degree of the laceration. In this, the laceration is less than 1 centimeter. There is no urinary extravasation because the collecting system is not involved in this trauma. Okay, so there is laceration with a contained hematoma within the Gerota's fascia. The collecting system is not involved. And then in grade 3, there's a larger laceration, which is more than 1 centimeter. Grade 2, it was less than 1 centimeter. Grade 3, it is more than 1 centimeter. But in this also, only the renal cortex is affected. There's no urinary extravasation because the collecting system of the kidney is not damaged. And the hematoma is also contained into the Gerota's fascia. So laceration, more than 1 centimeter, capsule ruptured, blood inside the Gerota's fascia, no breach of the collecting system. Now, going on to grade 4. In grade 4, there are two things that you need to see. One is that the cortical laceration can be 1 centimeter, can be 2 centimeter, can be 3 centimeter. The size, the degree, the extent of the laceration is not the issue. The main issue is that the collecting system is also damaged. Okay, so if the collecting system is damaged, there will obviously be urinary extravasation, there will be hematuria, the patient will have blood in his urine, and this is grade 4. Okay, the other thing that you see in this diagram is there is hilar injury. So if there is hilar injury of the vessels at the hilum, then that is also grade 4 injury. Okay. Now, how will you differentiate from grade 5? In grade 5, there's a completely shattered kidney. The pole may be lying separately, the upper pole may be lying separately, there can be multiple lacerations, the collecting system will be involved, the Gerota's fascia may be breached, the renal hilum may be absolutely transected. These patients obviously are most likely to be unstable in your initial assessment in a trauma room. So these are the patients which will require urgent attention. Now, again, recap for for all of you. Hematoma, grade 1, less than 1 centimeter, grade 2, more than 1.1 centimeter, grade 3. Any degree of cortical breach with collecting system involvement, grade 4, or hilar thrombosis, grade 4. Shattered kidney, breach of the lower pole separately or the upper pole separately, transection of the renal hilar vessels, or a breach of the Gerota's fascia. This will obviously be grade 5 injury. Okay, this is the pedicle injury that I was explaining to you initially. In this, you can see that this is the pedicle which is coming from the aorta. And once the kidney is moving, you see that there's stretch of the pedicle over here, and there's break of the intima. Once there's break, there's bleeding inside. And when there's bleeding, there's thrombosis of this vessel. Okay, so now why is realizing that the grade of the renal injury is, why is it so important? Why are we spending so much time on the grading? It is simply because your management will depend on the grading. Now, for all practical purposes, remember one thing. If the patient has come to you with renal injury, and that is their sole injury, you are going to try and manage this patient conservatively. Okay? You do not intervene unless indicated. What are the indications? The patient becomes unstable. What does unstable mean? The blood pressure goes down, the pulse goes up, and the patient needs inotropic support, multiple transfusions, has an expanding retroperitoneal hematoma. Now, once the patient presents to you in the emergency room, what you need to do is you need to examine the flank and you need to mark the degree of hematoma. And if you see that in the preceding hours, the following hours, this collection is enlarging, then this will mean that there is constant bleeding into it. If there is constant bleeding into it, then you have to intervene, because if you don't, then the patient is going to lose a lot of blood and hence might not survive. So when do you intervene? In cases in which the patient is clinically unstable, in cases where there is retroperitoneal hematoma enlarging and this is called as expanding hematoma. When do you not intervene? If the patient is stable. If the patient is stable, you do not intervene. Why? Because once you start operating on a patient with renal injury, you inadvertently have to open the gyrotous fascia. Now, gyrotous fascia, as I told you, is a fibrous encasing of the renal kidney, of the kidney. And any bleeding within this will put pressure on the kidney and will stop the bleeding. It will help you in hemostasis. Like if you have a bleeding from somewhere, what do? You put your thumb over there, you put your hand over there, and you apply pressure for 3 to 5 minutes. That is what you do. That is standard protocol. So this gyrotous fascia, if it is not breached, will help you put pressure on the bleeding area. It will help you contain the hemorrhage. It will help you achieve hemostasis. So remember this, whenever you try to operate on such patients, what will happen is this hemostatic effect of the gyrotous fascia will stop. It will disappear. And sudden torrential bleeding can occur, as we all know, that a kidney receives 1.2 liters of blood per minute. So when you actually explore for renal injuries, then you have to be willing and ready to do the nephrectomy. In a study which was published in urology clinics of North America, there was a data of about 70,000 renal injuries. And in those 70,000 renal injuries, what happened was they compared as to how many patients who underwent exploration survived with their kidney. That means to say that if you explore for even a grade 2 renal injury, even then you have a very high, that is about 70% chance of having to do a nephrectomy to save the patient's life, because at the table, the sudden gush of blood comes out from the girotas. In grade 3 and 4, this goes up to 80%. In grade 4 and 5, this is 100%. So in order to preserve the kidney, it was decided based on this large study that maximum chance of conservative treatment would be adopted, and patients do recover on it. And that is how it is managed nowadays. So coming to absolute indications for surgery, uncontrollable renal hemorrhage, multiply lacerated shattered kidney, grade 5 obviously, main rectal vessel avulsed obviously will not settle, penetrating injuries usually, because they will blow a pole of the kidney away and the bleeding will not stop. And obviously the gyrotous fascia, if there's a penetrating injury, you know that the gyrotous fascia is now breached. So containment of this bleeding will not happen because of the gyrotous. So in these patients, you have to intervene. Again, a pictorial depiction of the grading again. Now, this is the important slide that you have to see. I'm sorry, it's a busy slide, but it's a very straightforward slide. I will go through with this to make it easy for you to understand. Now, somebody who has come to the emergency with blunt trauma, microscopic hematuria. Microscopic hematuria is what hematuria? The hematuria which is not visible to the naked eye can only be seen under the microscope. In this patient, you will not do any further studies. No IVP, no CT scan, nothing. You just have to observe. Okay? Now, if a patient comes to you with blunt trauma and has gross hematuria is which hematuria? The one which is visible to the naked eye. Or somebody who has come with microhematuria but has shock. In these patients, there will be two possibilities. The patient can be stable or the patient can be unstable. If the patient is stable, you will do an abdominal CT scan, okay? Just like I talked in the start. Grade 1 to 2 injury, observe. Grade 3 renal injury, and if the patient does not require a laparotomy, you just observe. Grade 3 renal injury, if the patient requires a laparotomy, then you will do selective renal exploration. In the current scenario, there's even opportunity to do angioembolization if there is a polar vessel which is bleeding profusely. So even in penetrating injuries, the latest recommendations are that if there is a polar artery which is bleeding and the patient is stable enough, you can go for angioembolization of that polar artery. Okay. So this is how you proceed. Now, grade 3 renal injury, in which no laparotomy is indicated, then you have to observe. In grade 4 and 5 renal injury, there's selective renal exploration. Again, the key word is selective. Selective means patient who are unstable, who are undergoing laparotomy for some other reason, who in which you have an opportunity to see if there is an expanding retroperitoneal hematoma or not. But remember again that these patients are 80 to 90% probably will get a nephrectomy. You will not be able to save the kidney. Now, if the same patient with blunt abdominal injury who was unstable at the time of presentation in the emergency, you do a one-shot IVP. What is an IVP? An IVP is a study, a radiological study in which you do a plain phase, then you inject the patient with a contrast, and you do a nephrogram phase at 5 minutes, and then you do a 15-minute film, a 30-minute film, a 45-minute film, a post-void film. And in patients who are obstructed, you can even have a 3-hour film, 6-hour film, 12-hour film, and 24-hour film. So that is how an IVP usually is done. In this patient, this unstable patient for trauma, however, a term is known as one-shot IVP. Now, one-shot IVP is what? It is when you give the contrast and you take one film at 10 minutes. Why do you do this? Why do you have to do this? Because supposing a patient comes to you in the emergency, you do not know if they have 2 kidneys, you do not know if they've had a previous nephrectomy for some reason, if the patient is not able to give you history. Some people are born with 1 kidney, some people have a non-functional kidney, some people have an abnormal kidney. So for that reason, you do a single shot IVP. The other reason is that you have to ascertain the degree of injury in this patient. It will tell you about extravasation of the contrast. It will also tell you about the perfusion of the kidney, whether it is being perfused. Like in grade 4, I told you that if there is thrombosis of the renal artery or vein, then the kidney might not be perfused. You won't be able to see it on the IVP. Okay, so if there is abnormal IVP or inconclusive, then you have to do renal exploration. Abnormal IVP means कि जिसके अंदर किडनी नजर नहीं आ रही, ठीक है, तो उसके अंदर आप एक्सप्लोरेशन करेंगे. अगर नॉर्मल IVP है, if the IVP is normal and the patient is stable and the retroperitoneal hematoma is stable, it's not expanding, then you will observe. If there is pulsatile or expanding retroperitoneal hematoma, then you will do a renal exploration. And remember, in all explorations, you are going to most likely end up doing a nephrectomy. So you have to be sure about it. And the family has to be counseled about it. The patient, if he is responding, if he is conversing with you, you have to tell them that this might end up in doing a nephrectomy. So that is how you make your decisions. And with this, the topic of renal trauma, and this is finished. And the follow-up, if somebody has had a renal injury, the follow-up is usually by ultrasound. If somebody has had a grade 1, 2, 3 renal injury, and you have managed them conservatively, you keep an eye on their hemoglobin, you keep an eye on their urine output, you keep an eye on their creatinine, and then at 15 days, 1 month, you do an ultrasound just to see. Sometimes what happens is, due to injury, there is ischemia of that kidney, and the kidney can become atrophic. So the reason for this follow-up is that the patient should be aware of his reserves. Supposing somebody has a trauma, you manage them conservatively, but unfortunately their glomerular filtration rate on that side, the contribution of that kidney went down for some reason. The patient has to now know that they have only 1 functional kidney. So these are all very important life lessons. So I hope I've been able to explain renal trauma to you in detail. If you have any questions, you are always welcome and most welcome to ask. Thank you so much for your attention.